All right, good morning, everyone. Thank you so much for being here. Welcome to our Hot Topics in Prostate Cancer Symposium. If you're here for a Zumba class or something else, you might need to be in a different building. But thank you all for joining us. If it's your very first time here at Wellness House, welcome. We're all very glad you're here. Just a few announcements before we get started. I want to point out just a couple highlights. You may have saw that there's a folder on your chair. Just a few highlights from that we want to make sure you're aware of. We have a monthly prostate cancer networking group. It meets every second Wednesday from 9:30 in the morning till 10:30. Michael Williams is our staff facilitator. I don't know if he's in the room right now, but you may have saw him on your way in, so feel free to say hello. And then just to let you know about our agenda this morning, we'll be having our 3 physicians speaking. While they're speaking, in each one of your folders, you'll see that there is a card that you've received. Feel free to write down any questions you have during the presentations on those cards. Some volunteers and myself will be through the audience every little bit here to collect those cards from you, and then the panel discussion will read from those cards for the doctors to answer. All right, so if you would like to join me in a warm welcome, I'd like to welcome Dr. Patel, Dr. Kundu, and Dr. Dean.
You're up.
All right, thank you very much. There you go. Thank you.
So good morning, everyone. Thanks for being here. It is my pleasure to be here. I'm Amit Patel. I'm a urologist with DuPage Medical Group. We have an integrated oncology program, so I'm one of the urologic oncologists there. And my topic today is going to be an update on screening and active surveillance for prostate cancer. So we're going to go through some prostate cancer statistics, an update on prostate cancer screening, discussion about adjunct testing with PSA, and active surveillance. So some statistics. I know some of you have experience with prostate cancer. Some of you may be in the screening group. But there are 180,000 new cases that are estimated to be diagnosed in 2016. 26,000 deaths are going to be estimated in 2016. It's still the #1 cancer incidence for males and the #2 cause of cancer deaths in males. The overall probability of getting prostate cancer is 1 in 7. So overall in your lifetime, it's a 1 in 7 chance of getting prostate cancer. And as you can see from age 50 onwards, the probability increases. The good news is the overall incidence is decreasing of prostate cancer. Overall death rate is also decreasing. As you can see, the 5-year relative survival rates from the 1970s to the 2000s have significantly decreased. The 5-year survival in 2005 to 2011 was 99%. Prostate cancer deaths started decreasing roughly around the 1990s onwards. This is this maroon line here. And that's mostly due to PSA. That was when the advent of PSA came about, and that was used in the aid in the management of prostate cancer and diagnosis of prostate cancer. What is PSA? It stands for prostate-specific antigen. It's a protein made exclusively by the prostate. It has reproductive purposes. It was approved by the FDA in 1986 to aid in the management of prostate cancer patients, and it was approved in 1994 for screening and diagnosis of prostate cancer. So since the 1990s, we've been using PSA to screen for prostate cancer. So it's over 30 years. And really, it wasn't until more recently that it came under more scrutiny. And the United States Preventive Services Task Force looked at PSA and PSA screening and prostate cancer screening in general, and they gave it a grade D. What a grade D means is that they recommended against prostate cancer screening. So they felt that there was moderate or high certainty that screening for prostate cancer has no net benefit, and that maybe the harms may outweigh the benefits of screening. And the cited reasons were a reduction in prostate cancer mortality, stating that it was very small. We saw that prior graph showing the prostate cancer mortality has decreased ever since the 90s when PSA came about. So this is controversial there. That a substantial percentage of the men will have indolent cancer, and again, that's also controversial, especially urologists in this group. When we see patients with high-grade, high-risk prostate cancer, it's hard to say that a substantial percentage of men have indolent cancer. The harms include fevers and bleeding from prostate aspirations, which can happen, as well as erectile dysfunction and incontinence from treatment of prostate cancer. This is really important to look at because this task force was made up of 16 members. Some of them were non-doctors. Some of them were general medicine practitioners, pediatricians, geriatricians, some healthcare executives, and 2 OBGYNs. But medical oncologists, urologic oncologists, or radiation oncologists, there were none. So anyone that deals with prostate cancer, diagnoses it, manages it, none of those doctors or physicians were on this panel that gave this recommendation. And this is huge, actually. And there's a bill in Congress today. It's called the Blackburn-Rush bill. Marsha Blackburn from Georgia and Congressman Rush from Illinois have proposed this bipartisan bill to actually reform the United States Preventive Services Task Force. They want to make it more open. They want to include specialists on the task force. And when they come out with a recommendation and a blanket statement, like what they did for prostate cancer screening, they wanted to go through some scrutiny from the medical community, from public forums. So there's going to be a reform. That's what the bill is asking for. And I don't think it's going to get approved this year with a lame duck Congress, but hopefully next year it should get approved, or it should get passed. But let's look at some of the studies that they looked at. So this task force looked at some studies, and they said that it wasn't approved. And just briefly, the study they put the most weight on was the U.S. study. And this was a screening study of 76,000 men. It was actually a negative study. It showed no benefit to prostate cancer screening. The other 2 studies they looked at were the European and the Swedish study, and they actually showed a benefit to prostate cancer screening. If we dissect the U.S. study just a little bit, just briefly into this, there were 76,000 men, all ages 55 to 74, so in that group where they benefit from prostate cancer screening the most. The screening group had a PSA once a year for 6 years. The non-screening group, there were no formal recommendations. When they looked at the study and they put the data together, they found that there was no benefit to prostate cancer screening with regards to survival or metastases. But what they did find when they scrutinized the data was that 52% of that control group that wasn't supposed to get screened actually had PSA screening, so it was contaminated. 44% of men had PSA tests before even randomization, so they were essentially screened. So it was really an intensive screening versus a partial screening trial, and so it was really destined not to show a difference. A more recent updated independent review demonstrated that 90% of those patients who were supposed to be in the non-screening group actually had PSA screening, so further contamination was found than initially reported in the study. And so it was a flawed study to begin with, but that hasn't changed the recommendations from the task force. And there are implications to their recommendation. And what we can see here in this study, and I'm showing you data because I think it's important to see what's really happened since they made that recommendation. So they made that recommendation in late 2011, 2012, and what you can see here, the yellow line and the blue line, is prostate cancer screening rates in 2005 and 2010. Well, after they made that recommendation, this is in the United States, the prostate cancer screening dropped off significantly. And it was significant in patients greater than 50 and less than 75. And that's the group where we find that prostate cancer screening has the greatest benefit. So that's real data that's shown that their recommendations made a difference and that we're screening less for prostate cancer using PSA. This also has made a difference in the diagnoses of prostate cancer. So between 2011 and 2012, there's been a 28% decrease in the diagnosis of prostate cancer. And that's, you could dissect the data further and say, well, we decreased the low-risk disease diagnoses by 38%, which is great. We want to try to decrease that disease where it may not have clinical implications or significant implications for patients. But it also decreased the intermediate risk disease by 28% and high-risk disease by 23%. So what we're potentially doing now is delaying the diagnosis of patients that have significant cancers. And so real-world implications and effects from that recommendation that the task force put out. We know that it saves lives, prostate cancer screening, but we have to minimize over-detection and over-treatment. And I think they were looking more towards minimizing that, but they failed to see that it does save lives. So the AUA, the American Urologic Association, put out their own recommendations, and we know that the greatest benefit in prostate cancer screening occurs in men ages 55 to 69. And so they don't recommend screening in patients under 55. Now, if you have a family history of prostate cancer or you're African American, then you should get screened, and the AUA does recommend that. The interval screening period is 2 to 4 years. So you can get a PSA if it's normal. You can wait up to 2 years and get another PSA. Now, if your PSA is rising or if it's changing, that doesn't mean you have to stick to the 2 to 4 years. You can get another PSA within 6 months or a year, and they've included that in their recommendations. And that really no men greater than 70 or a life expectancy of less than 10 years should be screened for prostate cancer. And that's to minimize over-treatment or over-detection in patients where it may not make a difference. Now, there are some men, and as our population ages and healthcare advances, we're having patients who are in their 70s that are healthy, that may not be on any medications, whose family members lived into their 90s. I think if you have an educated discussion with your doctor on screening for prostate cancer, you may actually benefit from prostate cancer screening in this age group. So something that we want all patients to talk to their doctors about. PSA is not a perfect test. I tell patients there's 3 major reasons why your PSA may go up. It could be because of benign prostatic hyperplasia or growth of the prostate. It could be because of inflammation or infection in the prostate or prostate cancer. So before we move to a biopsy when a patient's PSA is elevated, there are other tests we can do nowadays before we do that. And one of them is the PHI, the Prostate Health Index. It's a blood test. It combines serum PSA, percent free PSA, and Pro2 PSA. These are all blood tests. It's computed in a proprietary algorithm. And when you get the result, you can then see that they give you a result of their probability of having prostate cancer at biopsy. So this is a probability of if we biopsied you that you might have any cancer. So again, it's a blood test. It gives you the probability of finding any cancer, so Gleason 6 to Gleason 10. And there is some evidence that higher PHI values may indicate higher grade cancer. And it significantly improves the prediction of biopsy outcome over PSA or percent free PSA alone. So it's another adjunct test that we can use before we move forward with biopsy. Another test is the 4K test. It's the 4 kallikrein test. That's what it stands for. And it uses the 4 proteins PSA, free PSA, intact PSA, and the human kallikrein 2 protein. But it also includes clinical factors such as age, digital rectal exam, and if you've had a prior negative biopsy. And again, it's a proprietary algorithm which they computed in, and it provides patients with the probability of high-risk cancer. So now, what they mean by high-risk cancer is Gleason 7 cancers and above. So whereas the PHI gives you any cancer, the 4K is giving you Gleason 7 and above cancer. So it's a little bit more informative, some would say, and it can, again, help us. It's another test that can help us if we want to move forward with biopsy. The test I've been using more of is a multi-parametric MRI of the prostate. It's been shown to help identify areas in the prostate that may have been missed by negative biopsies or that are suspicious for cancer. The NCCN, actually, the guidelines actually support its use in patients that have prior negative biopsy or for use in active surveillance. And it's being increasingly used prior to initial biopsy. There is a scoring system with the MRI of the prostate. It goes from 1 to 5. It's called the PIRAD score. They're actually looking at different characteristics. So multi-parametric MRI, what I tell patients is what that means is we're looking at the same organ with different windows using different imaging sequences. And we can then use what we see on those sequences to score the lesions if there's something there. And 4 and 5, there's a higher likelihood of that lesion being cancerous. 3 is indeterminate, and 2s and 1s are usually benign. Studies have shown that there's a 30% more high-risk cancers found when you use MRI prior to biopsy, and 17% fewer low-risk cancers are found. That means if you have a negative MRI and you don't biopsy, you might find you're not going to diagnose these low-risk cancers, or if you see something, it's more likely to be a higher-risk cancer. And there's a greater correlation with the pathology when MRI is used at biopsy to the pathology at surgery. In our group, we've been using it since 2014. And we use it for active surveillance prior to treatment. We're also using it for patients that have elevated PSA. So in my practice, anyone that I'm thinking about taking to biopsy, I'm going to ask for an MRI of the prostate first. And we're studying our patients as well. We have 180 patients that underwent multi-parametric MRI prior to biopsy. And what we find is that the positive predictive value is 89%. So if there's a lesion on the MRI that's suspicious for cancer, we're hitting that cancer 89% of the time. The negative predictive value is actually 75%. So what we tell patients is that if you have a negative MRI, it doesn't mean that you don't have cancer. You may still have cancer or harbor a cancer in the prostate. But what we found is those patients that we biopsied, there were 5 of them that had a negative MRI that had prostate cancer. 4 of them were Gleason 6, very low-risk cancers. and one had a very low volume Gleason 7. So they're lower volume or insignificant disease is what we're finding. Just to give you a case example, I had a patient I saw in the fall. He was 63. His PSA was 4.3, and on exam, I felt a nodule at the apex. So I ordered an MRI of the prostate because I was going to move forward with the biopsy, and it was actually rejected by insurance. And so we ended up moving forward with the biopsy. It was a transrectal ultrasound-guided biopsy, 12 cores, and it was negative. We then followed the patient. I checked the PSA 6 months later, and it was 6.2. At that time, I ordered an MRI, and this time his insurance company approved it, and we found a 1 centimeter lesion at the anterior location of the prostate. So most of our biopsies, when we initially take them, are in this peripheral zone of the prostate, and this was sort of central transition zone, as we call it, and anterior, and likely missed by my initial biopsy when I biopsied him. So I actually took him back for another ultrasound-guided biopsy, and what you can see here is this is the lesion on the MRI, and this is the lesion very clearly seen on ultrasound. So I didn't have to put him through 12 cores. I literally targeted that lesion, put 4 cores, took 4 biopsies, and all 4 came back with Gleason 8 cancer. And so, he was probably delayed diagnosis by about 8 months because we didn't get the MRI or we missed it. But luckily, he has organ-confined disease, and it's probably, I think he's set for treatment in the next couple of weeks. So, just to summarize, PSA screening, it does reduce mortality, but it can lead to over-detection and over-treatment. But we have to be smarter by using more intelligent use of screening for prostate cancer, and that includes additional serum tests and imaging techniques before we move forward to biopsy. So when patients are diagnosed with prostate cancer, our treatment algorithm should include an assessment of their life expectancy, their overall health status, tumor characteristics, and a discussion should be held with the urologist and even radiation oncologists before any treatment decisions are made. And this is really a paradigm shift in cancer treatment overall. We used to be very disease-focused, and now we're more patient-focused. We're looking at quality of life factors and issues, patients' rights and empowerment, as well as survivorship. For low-risk or very low-risk prostate cancer, the criteria from the NCCN is that you have organ-confined disease, Gleason 6 prostate cancer, the PSA is less than 10, fewer than 3 cores, or less than 50% involvement in each of those cores, and low risk is just Gleason 6 organ-confined and less than 10. How do we know, just more than just these clinical parameters here, that you have low risk or very low risk disease? And Dr. Dean is going to be going through this a little bit later, but there are epigenetic tests out there now where we can take your tissue from the biopsy and do gene expression testing on them. And Oncotype, Prolaris, and Promark are 3 of the tests, and I won't get into this too much because I know Dr. Dean is going to have a more detailed presentation on this. But we can use these tests now to risk stratify even for treatment and to fall into active surveillance. So for very low risk and low risk disease, the guidelines suggest that you have 3 options for treatment. One is active surveillance or observation, radical prostatectomy, or a form of radiation therapy such as external beam radiation therapy or brachytherapy. Now, why can we offer all of these treatment options to patients? Why do you get these choices for this type of cancer? And the reason is survival for low-risk cancer, cancer mortality is very low. If you look at this Boston study, median follow-up was 8.5 years. There were over 400 patients with Gleason 6 prostate cancer that were treated, and no patients died of their disease. So we can treat these patients. No patients are dying from Gleason 6 prostate cancer. A much bigger cohort study or retrospective review from Cleveland Clinic, Memorial Sloan Kettering, Baylor, Hopkins, and Michigan was done. 24,000 patients were looked at. The 15-year mortality for Gleason 8 to 10 prostate cancer was 49%. The 15-year mortality for Gleason 6 prostate cancer is 1%. So in other words, the 15-year survival for patients who have Gleason 6 prostate cancer is 99% when treated. And all patients here were treated with prostatectomy. In over 3,700 patients with Gleason 6 prostate cancer, no patients died from prostate cancer. Well, actually, 1 patient died, but I know the author of this study, and when they went back and looked at this 1 patient that died, and they reviewed their pathology, it was a Gleason 7 prostate cancer. So that's why we can use active surveillance for these patients, because we can actively monitor the course of disease, with the expectation that we can intervene with curative intent when the cancer progresses, or if it grows, or if the PSA rises. And so if you have Gleason 6 prostate cancer, you can fall into active surveillance as a form of management. And if it changes, you can, with the studies I just presented, you can be rest assured that you can still get treatment and potentially have cure. So most active surveillance protocols, the PSA is checked every 6 months, exam every 12 months, repeat biopsy within 1 year, MRI of the prostate, and I can also include epigenetic testing as well for this. The advantages are that 2/3 of patients would avoid active treatment. You avoid the side effects of treatment, whether it's radiation or surgery. Your quality of life is maintained, and there's a reduced risk overall. The disadvantages may be that you need repeat testing, so repeat PSAs, MRIs, prostate biopsies. There may be some psychological distress for patients knowing that they have a cancer that's untreated, and they might be thinking that there's a rare chance of missing an opportunity for treatment. And I put an asterisk here because there are studies that have looked at this. So these are just 3. There's a European study, the Hopkins study, and a UCSF study. These studies demonstrated that patients who were on active surveillance that eventually had treatment, there was no difference in their pathological outcomes or recurrence rates. There was no, in their biochemical recurrence-free survival after surgery was similar, so their PSA failure was the same, and there were no difference in pathological outcomes at surgery. So patients can be followed, and some of these patients were followed for a median of 2 years after surgery. More and more patients are electing to go under active surveillance when they have low-risk cancer, and this was a paper produced at the AUA, and I thought it was just interesting because this was a community practice. So you know, this is a huge improvement over what I would say even 5 years ago was happening in the community. For very low-risk patients, 70% chose active surveillance. I think this is a big difference from what we used to see 5 years ago with patients, and so that's huge. That's progress. Active surveillance outcomes, the 2 biggest cohorts are in Toronto and at Hopkins. You can see here Hopkins has almost 1,300 patients that they've followed under active surveillance, a median follow-up of 5 years, and the prostate cancer specific mortality is 0.1%, and the rate of metastatic disease is 0.4%. You can see the numbers for Toronto are higher, but Toronto, there were patients that they put under active surveillance that had Gleason 7 or higher disease. So the Hopkins is certainly more strict criteria, and you can see the benefits of that in the outcomes. This is a little bit more from the Hopkins data, 1,300 patients. Their 15-year survival, overall survival, so this is patients overall, when they were followed, 69% survived, but for cancer-specific survival, it was 99%. So for most of these patients on active surveillance at Hopkins, they're dying from something else other than their prostate cancer. And really only 2 patients died from prostate cancer. One of those patients in the study died at 16 years out from their diagnosis. The other one died at about 3 or 4 months, but they actually were lost to follow-up. So they're not really sure, the authors aren't sure what happened to that patient, but they were diagnosed at Hopkins. He fell into the study, but he never followed up, and they found that he died of prostate cancer a few months later, so it's unclear. So just to summarize, active surveillance is a viable management option for very low risk and low risk cancer. We can use epigenetic testing and MRI to stratify patients to see if they are good candidates for active surveillance. It's gaining traction amongst providers and patients here in the community and at academic centers, and the oncologic outcomes are very favorable. Thank you.